Welcome to this series of videos related to curriculum development in health profession education. And today, the 8th video of this series, which will be about curriculum integration in health profession education. My name is Mohamed Hassan Taha. I am medical educationalist with the passion to advancing health profession education to improve the population health. And these videos has been developed to support postgraduate healthcare education students at master and PhD level and faculty members who involved in curriculum development, delivery, and assessment. This session will be about curriculum integration in health profession education. And in this session, we'll clarify the concept, identify the different level, planning, integration, delivery, and the assessment. Let us start with the definition. Defining the curriculum integration, it is the organization of the teaching material and teaching matter to interrelate or unify subjects frequently taught in a separate academic course or department. Also has been defined as the teaching of different subject areas in thematic manner so that the different disciplines are not emphasized. And also defined as fully synchronous trans-disciplinary delivery of information between foundational science, applied science throughout the years of the medical school. There is international call for curriculum integration and integration in medical education and health professional education, including the accreditation standards globally, and in particular the World Federation of Medical Education and also the GMC into more doctors. And it is stated clearly there that we strongly favor true integration of courses, both vertical and horizontal, using the term in sense of interdisciplinary synthesis, not simply coordination or synchronization of departmentally basic component, because many medical schools and health science schools, they are doing only coordinations, not integration. We need to move from this shape to this shape, from this one to this one. And there are two main types of integrations, horizontal and vertical, and also we have other types, spiral integrations. Horizontal integration is defined as integration across the disciplines, but within a course or a period of time. While for the vertical integration across the curriculum, the entire phase of the curriculum, from like introducing the clinical science early in the curriculum and continue with more weight till the end, and while keeping the basic science with more weight at the early phase of the curriculum and continue the end with a small amount. We have a spiral integration, and it is about revisiting the content with different levels across the curriculum. As we can see here, for example, we are in this curriculum, there is the revisiting between the growth and development and aging from early phase of the curriculum till the end. And this is also another example of revisiting the basic science, the communication skills, and the clinical science, and the abnormalities from the beginning till the end. And also this is another example, a third example for integrating or instilling social determinant of health from early phase of the curriculum till the end of the curriculum. This for the spiral approach, and here for the horizontal approach. So why is the integration? It is the solutions which I am urging to eradicate the subject which kills the vitality of the modern curriculum. So that we need to make it together, and we need to make it in this way, as if we are making a cake in this way. So we put the different ingredients so that we have this as end product. And we should not make it like this way, where we should just do like coordinations, or like just putting things together, but they are not fitting each other. So we need to use the different ingredient here to produce this shape of the cake. The principles of integrations, they should be focused on core issues of the curriculum. And these focus issues, key issues and focus issues should be about the important concepts and the competencies that need to be covered. Integration enhance constructions of knowledge, because activate the prior knowledge and bring meaningful studying of different material together. It promotes application of knowledge for lifelong learning, because when they practice, the future healthcare practitioners, they need to use the basic science in a sense that to serve or to help solving patient problems or community problems. Foster clinical thinking and enforce also faculty development. And there are several levels of integrations. And one of the best models of showing the levels of integration is the integration ladder developed by Ronald Harding. And as you can see here, starting from the lower level is isolation, to the highest level is trans-disciplinary. And the first four level can be done at individual and department level. The second level, the second phase at departmental institutional administration, and the higher level at program level, which include multidisciplinary, interdisciplinary, and trans-disciplinary approach. So isolations is fragmentations, having the different subjects here, no consideration of other disciplines, and teaching anatomy, pathology, physiology in a different way. So learning will be in this way. The second level, highest level from isolation, is awareness. The faculty member, they purely discipline, but the content of the other subjects, they are considered together. They are avoiding redundancy, repeating, and avoiding duplication, and they try to design the timetable in a way that consider some sort of coordination and sequence of the sessions rather than they are integrating, and it's better level than the isolation. The third level is harmonizations. There is a connection and there is a consultation among the faculty. Still discipline based, still remain discipline, and each course contributes the curriculum, and there is formal or informal consultation. The fourth level is the highest, higher and better than this. It's called nesting, and nesting is related to infusion. Like this, subject-based still, content drawn from other subject, discipline, and used to enrich teachings. For example, bringing pathology with clinical, bringing pharmacology with the chemistry, bringing anatomy with the surgery. So for this reason, it's called nesting. You have the subject, but you bring from the other, you do some sort of nesting. This is good in comparison to the first level is isolation. But still, we need to go further, because this is still at teacher level or medical teacher level. The fifth level is temporal or temporal coordinations, like parallel or concurrent teaching. Each discipline is responsible for the content, but related topic from the disciplines they are putting in the tables. Coordination, not integration, coordination. So students are to do the links. Either we are using system-based, we are producing the timetable weekly, trying to do these coordinations, and so on. Something still, now we are bringing something together, and these examples are in which we are considering this is not integration, this is coordination. The highest level, the level is higher. It's not the highest. The level is higher than the fifth level. The sixth level is called sharing level, in which there is a joint teaching. Two disciplines, they come and deliver the class together. Consider overlapping or complementary each others. It is departmental rather than institutional. For example, a community health department is teaching with the child health programs for the immunization and such topics and so on. Combine clinics, surgery and medicine, and obstetrics, discussing obstetric surgical emergency with three departments together. This is called sharing in this way. For example, another example is reproduction, growth and development sections. This in early Brown medical curriculum in 70s, teacher from pediatric to the ops and so on, and plan the lectures together to attend the other. The higher level than the previous level, which was about sharing. The higher level is correlation. in which subject-based courses, classes for the most time, and join session and delivering this session together. The 8th level is complementary, mixing the programs, integrating sessions are the major feature of the program. Still subject-based with some sessions, contributions, other both should be considered in exams, and for example, having like symposium and so on. It is a relatively good part of the integration because having mixed program together. Now we'll go to the higher level, and in which are program and colleague level, and this is the real type that of integration that we need. This level is better than before. 8th level, this is a 9th level, is multidisciplinary. It's why it's called web or contributory, in which bringing number of subject area in a single course. Theme is viewed through the lens of the discipline. Contribution of each discipline are stated in the curriculum, and this example of that. For example, bringing together, and the title of the sessions are a single session. This is one of the better level than before. This interdisciplinary is better than multidisciplinary. It's called monolithic because study of phenomena from more than one discipline and simultaneously at the same time, as you can see here. Now we become better than before. Content from this discipline combined into new course, and there is a loss of the discipline. The best level is called trans-disciplinary. This is the highest level of integration, in which there's the fusion, immersion, and authentic. So things become like this. Exactly. All come together. There is no discipline, bypass discipline, boundaries, field of knowledge rather than selected topic and theme, and discipline become as a part of real life. So this is a full integration. In a summary, 11 levels as introduced by Ronald Hardin. From isolation to transdisciplinary, the first 4 levels as individual teacher part, to some extent department, the second 4 level departmental institutional level, and the highest level multidisciplinary, transdisciplinary, interdisciplinary, transdisciplinary as a program level. So why curriculum integration? It reduces redundancy of the curriculum, support early clinical exposure. Accreditation bodies are urging for the adoption of the integration. It's more realistic. I highly encourage you to read these 12 tips for developing integrated curriculum, in which the authors discuss training the staff as important step, deciding the scope of integration, choosing the level of integration, go for vertical integration and horizontal, establish working group, determine the learning outcomes, identify the content, then create a theme, prepare a comprehensive timetable, select assessment methods, communicate with the student and staff, and commit to re-evaluation and revision. In a summary, curriculum integration is an important strategy in medical education, but it's a complex concept. Many levels of integration are present. The higher step, the less emphasis on the discipline role. Communication and joint planning is mandatory, but we need to distinguish between coordination and integration. And the most important step differ for a different situation. Thank you so much for watching this video, and always remind yourself with this. We need to have this kind of integrations, make it meaningful, and make it in this way. Thank you so much for watching this video, and looking forward to see you in the next video of this series, the 8th video, which will be about interprofessional education and health professional education.